morning. Thank you for the introduction, and thank you for inviting me to speak. I apologize, I have to leave right away to catch a flight, so thank you for allowing me to speak first. Before we talk about eyelid reanimation, I thought we should just talk a little bit about some anatomy and how all of this relates to facial reanimation. So the facial nerve nucleus, as we all know, is located in the lateral mid-pons. It then travels around the nucleus of the sixth nerve and then exits the brainstem. Importantly, after it exits the brainstem, it travels through the facial canal in the temporal bone. And this makes the facial nerve special related to other cranial nerves because it's the only one that travels through this armor of bone. And we think that this is one of the reasons that the facial nerve is more susceptible to inflammation because there's not a lot of room in here for swelling if there's an inflammation or infection. So the facial nerve is particularly susceptible to this because of this particular anatomy. It then travels through the stylomastoid foramen and then exits and branches through the parotid gland, making a number of branches that have different branching patterns, but ultimately these all innervate the muscles of facial expression. An important note here is that a supranuclear lesion causes a slightly different pattern from a peripheral nerve lesion, and that helps us understand the difference between a peripheral nerve and a stroke. A patient with a stroke will present with just lower facial paralysis because there's bilateral innervation to the upper part of the face. A peripheral nerve lesion will affect both the upper and lower, so that's a quick way to determine acutely, do you think this is a stroke or not? This series by Homan and Hadlock looked at the different causes of facial paralysis, and this is consistent with a number of other series, and by far and away the most common cause is idiopathic Bell's palsy. Followed by that are tumors and then various other infectious etiologies. Peterson then evaluated the prognosis after idiopathic Bell palsy and showed that the vast majority of patients will end up doing very well. On this score, a score of 0 is normal facial function, and a score of 4 is considered flaccid paralysis. And the vast majority, 71%, had a score of 0. 1 and 2 are considered acceptable. And so really only 4% of patients ultimately will go on to need some kind of chronic intervention for paralysis in the face. So how do we evaluate facial paralysis? We look at this man and we can easily pick out some of the problems here. He has brow ptosis, he has lower eyelid retraction. You might not be able to see it, but there's probably some upper eyelid retraction because of the levator that is no longer countered by the orbicularis, flattening of the nasolabial fold, and the lateral oral commissure as well. There are a number of grading systems that have been created to evaluate and also monitor the progression of facial paralysis. This is called the House-Brackman score. There's another one called Sunnybrook and an electronic one called the E-Face. But all of them tend to evaluate the face in zones. So House-Brackman evaluates the brow, the eye, the nasolabial fold, and then the oral area. But I think we as ophthalmologists recognize that this probably doesn't capture eye function as well as we normally do just on a regular clinic visit. Here they're looking at weakness of the orbicularis, and they assign a percentage to that. Is there asymmetry? Is there movement? But we probably think of the eye a little bit more sophisticated than that. We measure brow position, upper eyelid position, we assess the health of the cornea, we assess the lower eye position. And so I think that when we're looking at this, especially as ophthalmologists, there's not a very good established grading score the way they have for facial paralysis that we do for the eye itself. So here is a little girl, and we can see some of the issues in this video. She doesn't have a lot of brow ptosis, but she can't elevate her brow. Here you can appreciate the upper eyelid retraction compared to the other side, the lower eyelid paralytic retraction. She does have some lag ophthalmos, even with full forceful closure, and then she has lower facial issues here as well. Oh, sorry. One other thing that I wanted to mention was her blink. So if you look carefully when she blinks, the normal right side compared to this side, soon you'll see it. And I think what I'm going to argue is that although she can forcefully close maybe 50 to 75%, if you watch the blink on this side and compare to the other side, like there, she really doesn't blink at all. And so I want to talk a little bit about blinking. Blinking is a temporary closure of the eyelids that doesn't interfere with vision, but is very important for maintaining the tear film and protecting the eye from foreign objects. At rest, we blink about 16 times per minute. When we're a little more socially engaged, we tend to blink a little bit more. And as we all know, when we're reading, working at a computer, patients complain of dry eye. That's because we actually blink a whole lot less. The blink happens literally in the fraction of an eye, in 0.3 seconds, closure to open. And the closing velocity is about twice as fast as the opening velocity. Another important point is that the eyelid during blink has an anterior-posterior movement as well to provide kind of a squeegee action against the eye, to distribute the tears and also brush away any foreign debris. So there's a number of techniques to manage paralytic lag ophthalmos, and we're going to start with some static techniques. And these are the things that we use acutely because if we're not sure what or how much recovery we're going to get, we don't want to proceed to very invasive procedures yet. So things like aggressive lubrication, taping the eyelid at night, moisture chamber glasses, cumbersome but work well. Temporary tarsorrhaphies, again, these are very effective, but they don't look good. But this may be very effective in someone who has an acute Bell's and you're just waiting for it to resolve. The permanent tarsorrhaphy, again, is very effective at closing and protecting the eye, but it's not very pretty. And finally, lower eyelid suspension for paralytic lower eyelid retraction. Now, there's two dynamic techniques that I want to talk about, and there's many others that we could, but these are the two, and probably the most common one is the upper eyelid weight load. Typically, this is a gold weight, although platinum is also commonly used. The advantage of platinum is that it's 10% denser than gold, and so gives a lower profile when it's implanted. Also, there's some thought that it's more hypoallergenic. And a pocket is dissected through the orbicularis and the skin, and the gold weight is typically sutured to the tarsus. There are other techniques to place it in other places, but this is probably the most common location. And so here's a man standing up. He has paralysis of the left side of his face. And here you can see the weight. You can see it poking through the skin a little bit. He still has a little bit of lag ophthalmos nasally, covers most of his cornea. But the thing I want to bring to your attention is look what happens when he lies down. He has supine lag ophthalmos. So here, standing up, when he lies down, because the vector changes, when the patient is standing upright, the eyelid weight is being pulled down by the force of gravity. As he lies down, the vector changes, and in fact, it's counteractive, and it pulls the eyelid open. So this is an important thing to consider in patients when placing a weight. What happens at night when they're sleeping and they're at their most vulnerable? So here is our patient again. She's now had a weight placed in the left eye. And the first thing I want to point out is that it completely corrected the upper eyelid retraction that she had. And watch now with forceful closure. She has much better closure than she did before, but look at the speed at which it happened. I showed you earlier some data that demonstrated a blink happens in 0.3 seconds. This closure, forceful closure, if you wait long enough, sure, it goes down, but it takes 1.5 to maybe 2 seconds. Sure, that sounds fast, but that's still 5, 6, 7 times slower than a normal blink. So what can we do that's even better than a weight? And so next I want to talk about the palpebral spring. And I like to compare this to a safety pin. It has an upper and a lower arm and a fulcrum, and this is where the power comes from and means it does not rely on gravity. Importantly, these candidates have to be properly selected. Patients who are expected to have long-term paralysis and have maybe had a poor response to medical or conservative therapies. The Bell's phenomenon doesn't matter, but most importantly, we need them to be cooperative. This surgery takes a lot longer than a gold weight and requires a lot of intra and post-operative cooperation from the patient. It's made from stainless steel or nickel cobalt alloy and is very, very thin. We then bend it into this shape with the fulcrum laterally and place it through a standard upper eyelid crease incision that's converted into a lazy S over the lateral orbital rim. And here you can see the lower arm is then sutured to the tarsus. The fulcrum is sutured to the lateral orbital rim, and the upper arm is sutured to the superior orbital rim. One of the complications historically had been migration and exposure of the implant, but that has been ameliorated by placing the lower arm into a Dacron envelope and suturing that envelope to the tarsus, and that prevents the extrusion of the device. One of the issues is that the more the eyelid opens against the spring, the greater is the spring tension forcing the lid closed. And because of that, many of these patients develop pseudotosis postoperatively, and one of the ways to manage that is then to add a levator advancement to provide a little bit more lifting action of the levator muscle. So here's a patient who had a spring placed, and you can see the device in the lid and also that pseudotosis that I talked about, but look at the speed of the blink and how complete the eyelid closure is with the spring. So even as she blinks, there's a blink, there's better closure of the eyelid, and also if she were lying supine, because we're not relying on gravity, she still has complete and full closure. This study compared the outcomes of the weight versus the spring, and we can see in both the categories of the gain in blink and the gain in closure that the spring is better. And the one thing I do want to point out is that although the spring is very effective, the main complications has to do with postoperative adjustments, a whole lot more than if you place a weight. So in summary, remember the eye zones, not just the face zones when managing facial paralysis. Remember to think about supine lag ophthalmos. What is happening to your patient when he or she is lying down? The blink is important for tear worm preservation, and therefore we want to really try to reanimate the blink and not just closure itself. And finally, consider static versus dynamic eyelid closure techniques. Thank you.
Thank you, Dr. Peter. Any questions for Dr. Peter?
Yes, sir.
Tension in the spring itself, so that the tension becomes less, and then you don't have to advance the.
Right. So
is there any other material? What I mean to say basically is that is there any other more malleable material which you've tried using apart from stainless steel, because that can be quite rigid?
Yeah, that's a really good question, and I think it's an internal limitation of the design of this device. Because the more it opens, the more tension is put in the spring. I agree with you, maybe we could consider a different device, but then maybe it wouldn't have enough tension to close the lid as the alternative to that. So that is one inherent limitation that I think is difficult to overcome. And so that's why some people are talking about different types of devices, like a device that closes based on innervation from the contralateral eye. That's probably the holy grail of how to manage this, where if you provided a cross-face innervation to a device that then closed based on innervation from blink from the contralateral side, that's probably the best way to address this. We don't have that technology yet, but that is an internal limitation of this particular device, and I think it's difficult to correct it with this technology.
And how much has been your exposure rate?
Corneal exposure?
No, the exposure of the device.
In my experience, it's been 0. Again, the main reason for that is that we're suturing the palpebral arm to the tarsus. Many of them historically in the 60s and 70s when this device was developed were extruding because they were simply placed in a preorbicularis plane, and therefore they constantly were putting tension on the orbicularis in the skin and they would erode through it. But now that it's being sutured to the tarsus, that erosion exposure rate is very, very low. And in my experience, it's been 0.
What's the thickness of the wire that you use here?
It's 0.01 inches, and I apologize, I don't have the conversion to metric.
And the material you said is either stainless steel or?
It's a nickel cobalt alloy, so it's safe for MRI and airport scanners.
Thank you.
Thank you.